Neurodegenerative disorders. I find it interesting. Now, we have protein accumulation and deposition causing pathologies elsewhere in the body, but for whatever reason in the brain, protein accumulation is a particularly big problem. I mean, things like Alzheimer's, Huntington's, Creutzfeldt-Jakob disease. I don't know what it is about the architecture of the brain, but it's just really susceptible to protein aggregates. Just an interesting thing to know. Obviously, we're talking about the brain, so if you damage the brain, we're going to get dementia in a lot of these diseases. So this is specifically a reduction of cognitive abilities and or memory, perhaps behavioral changes. Neurodegenerative disorders also might cause movement defects. So I will say that neurodegenerative disorders will either cause dementia, movement defects, or both. Typically, we're going to see shrinkage of the brain, the cortex, and this can result in ventricular enlargement, just relatively speaking, and this is known as ex vacuo. Now, the types we're going to be going through are Alzheimer's, by far the most important one to know. It's the most common. Even in developing countries, it's the most common. Parkinson's is the second most common, and it's the most common neurodegenerative disorder is causing movement defects. Lewy body dementia in many ways mimics Parkinson's, but it kind of has like a reverse timeline in terms of the pathological progression. Vascular dementia is relatively common, and then a couple of the less common ones, but ones you have to know, frontotemporal dementia, Huntington's, Creutzfeldt-Jakob disease is very famous but very rare. And then multiple sclerosis is quite common. And this is arguably a neurodegenerative disorder and arguably a demyelinating disorder. So Alzheimer's, far and away the most common. Cerebrovascular, so people just getting like these little mini strokes that each time you have the stroke, you have a little bit of a decrease in your mental cognitive capabilities, and then you're fine, and then it gets a little bit worse. You have another stroke, fine, a little bit worse, etc. Alzheimer's. All right, most common, profound memory loss, so it's especially going to affect the hippocampus, and language issues as well. The pathophysiology, so we have this transmembrane amyloid precursor protein. And now this could be cleaved by the beta, or it could be cleaved by the alpha. If it's cleaved by the alpha, you're totally fine. No problem there. But if it's cleaved by the beta, it can be cleaved by the beta, and then the beta actually gets cleaved by something called the gamma. But again, we started with the beta pathway, hence the name. Now these beta amyloid plaques, beta because they went the beta rather than the alpha secretase pathway, can start accumulating, aggregating. I think specifically the beta sheets start stacking together, and they form these large extracellular aggregates, which we can see here, and this is bad for the brain. This can weaken the vasculature. This can lead to intracranial hemorrhages, which we talked about earlier, especially lobar hemorrhages. So bleeding contained to like the frontal lobe, or separately bleeding contained to the parietal lobe. Additionally, we should talk about this here, the tau protein, which stabilizes microtubules. This can be hyperphosphorylated. This causes it to leave the microtubules. They're now destabilized. They fall apart, and you start to get these tau protein aggregates. These are going to be intracellular. We can kind of see these here. We're going to have a similar thing with frontotemporal disease, but the tau protein it's going to be a little bit different. Remember, we also have tau proteins for people who have repetitive chronic concussions and develop CTE. As far as the genetic predisposition, well, remember that APP starts off the beta amyloid plaque. What chromosome is that on? That's on the 21st chromosome. So if you have Down syndrome, you have 50% more APP. This is going to lead to extra amyloid deposition. And I think it's like, I'm making this up, but it's close-ish. Like 50% of like people with Down syndrome by, I think, the time if they reach 40 or 50 are going to start to show signs of Alzheimer's. The apolipoproteins, there's actually two different alleles. The ApoE2, this is protective. So I couldn't think of a way to memorize this, and I asked my girlfriend, and without really hesitating, it's kind of funny how our brain works. She said, "Oh, the North remembers," like a Game of Thrones thing. The North, that's two words, remembers. So the North remembers ApoE2, you will have a better memory. You're less likely to get Alzheimer's. ApoE4, this one's easier, you forget. This is going to be the bad allele. Presenilin, it's actually in the name. Presenility, this is also another early onset Alzheimer's disease. You should be able to notice the beta plaques and the tau proteins as well on a histology finding. As with most of these neurodegenerative disorders, you're going to have shrinkage of the brain, especially the cortex. and especially the hippocampus, again, memory is going to be a thing. And for whatever reason, low acetylcholine is a finding and something you should know about. Some of the medications are going to try to raise acetylcholine levels. Parkinson's. So the second most common degenerative disorder, the most common one that leads to movement. And this is going to be a loss of dopaminergic neurons in the substantia nigra. Remember that this is the two-faced organ of the brain. There is the pars reticulata, which retards movement. It's part of the inhibition with the GPI of the thalamus. But then we have the substantia nigra compacta. And I think of compacta with D. CD, like a compact disc, has the dopamine. And substantia nigra is the black substance, and that's because tyrosine becomes neuromelanin, which it can also become dopamine as an alternative thing. So it starts with alpha-synuclein regulating the stability of these vesicles in the presynaptic terminal of these neurons. This is going to stabilize them, and it regulates the release of dopamine. So if you have an issue with the alpha-synuclein, one, they're going to start to aggregate. They aggregate and they form what's called a Lewy body. This is intracellular. Kind of see these here, even though this is just an illustration. The dopamine also is not properly maintained in the vesicles. It's going to spill out and causes oxidative damage, which is going to lead to the death of the cell. There is some opioid drug that they made in the 70s and 80s, and I guess when they manufacture it, commonly you get a very toxic byproduct called MPTP, which can I think recreate permanent Parkinsonian effects within just a couple of days. So this is really bad. The clinical presentation, traps. So people are going to have a tremor. Specifically, it's going to be a resting tremor. So if you start moving your hand to grab a cup of coffee or something, your tremor is actually going to get better. So when you're just sitting still is when it gets the worst. Sometimes it's called pill rolling. It looks kind of like you're trying to roll like an Advil pill or something between your pointer and thumb finger. Rigidity. So actually, let's start with this right here. So the tremor is actually difficult to explain. I looked up a paper and it went over my head. Why we get the tremor, but the hypokinesia, akinesia should make sense. We're destroying the substantia nigra pars compacta. Remember that this activates the direct pathway and inhibits the indirect pathway. So both of those effects are going to be pro-movement. So if we get rid of this, if we have destruction of the substantia nigra pars compacta, we're going to have less movement, hence hypokinesia and akinesia. So this postural instability, you have trouble stabilizing your back muscles and walking, shuffling gait, you have a hard time moving your legs. So you get this very, very specific walking gait. And this is going to lead to rigidity. So these are going to be upper motor neuron signs because this is in the brain. And they call this a clasp knife. And you see how a knife slowly opens, slow, fast. Same thing here. This is a clasp knife. Look at this. So it's resistance, then it goes. So again, that should make sense. The tremors, you kind of just have to memorize. That one's a little bit weird. You also get REM sleep behavior disorder. That is something quite noteworthy. So they're going to have issues sleeping, and then the REM sleep is going to be disturbed. And ultimately, so the movement disorder comes first. Eventually, you can get cognitive issues with Parkinsonism. Now, this is really the flip, the inverse of Lewy body dementia, right? So with Parkinsonism, we're going to have these dopaminergic neurons in the substantia nigra being destroyed, and then we're going to get more and more and more over time. And eventually, across time, we might start getting them in the cortex, and that's what leads to dementia. This is the opposite in many ways. So we're going to start with these Lewy bodies that are going to be formed in the cortex, more in the cortex, and then eventually it might make its way to the brainstem or the basal ganglia or whatnot, leading to movement disorder. So if you have cognitive issues first, or at approximately the same time, it depends, that is going to be Lewy body dementia rather than Parkinsonism. It's often misdiagnosed. And I guess it's just difficult to get brain biopsy to find these Lewy bodies. I think Robin Williams' wife, after he died, wrote an article saying that he had Lewy body dementia, and that's what led to his suicide. I don't really know about that, but I think for a lot of these diseases, it might be nice to put a celebrity name or face just to help you remember. And I don't know if you ever have to describe it to patients or I don't know. I don't know what the real utility is, but that's why I'm doing this. Hallucinations are especially common here. All right, so Huntington's. we have this Huntington protein, which is a normal protein, but we get this CAG repeat. Everyone's going to have a repeat. Most people are going to be 6 to 35. And if you get more than 36, then technically that's the cutoff where we now say you have Huntington's. The more repeats you have, the worse the disease is. It's going to correlate here. The more you have, it's also going to correlate with an earlier onset. So more repeats, it's going to hit you earlier and it's going to be worse. And there's something called anticipation, where every generation, so grandparent to parent to kid, the age of onset, in other words, the disease phenotype, in other words, the number, you're going to get more repeats as the generations increase. So that means earlier onset and worse phenotype. So these CAG repeats, it makes a polyglutamine structure. And I guess this causes the proteins to aggregate and cause mischief. And this can destroy lots of parts of the brains, especially the striatum, with an emphasis on the indirect pathway, which is why you get these hyperkinetic movements. Also associated with Huntington's is the NMDA receptor. It's overactive and you have too many of them, and so glutamate's going to rush into the cell, which causes calcium to rush in the cell, and so this excitotoxicity can cause apoptosis, which causes death of the cell. So chorea, this hyperkinetic sort of dancing movement, it's hence the name chorea, also emotional and behavioral changes as well. So as we mentioned, a little bit of calcium in is normal with the NMDA receptors for glutamate, but you have more of this with the Huntington disease. Vascular dementia, so also known as multi-infarct dementia. So you're getting lots of little mini recurrent strokes. This is progressively going to be damaging the brain, making it worse and worse and worse and worse over time. It's going to be the usual suspects: cardiac arrhythmias, chronic hypertension, obesity, smoking is obviously a big one, which are going to make you more susceptible to these mini stroke episodes. Remember that this is the second leading cause of dementia after Alzheimer's. Frontotemporal disease, so it's in the name. The frontal lobe can cause aphasia and issues with judgment. The temporal lobe, and we see this with Kluver-Bucy syndrome, where it causes these extreme personality changes. I don't know if you necessarily get the hyperorality and hypersexuality that you have here, like what you would have with an HSV infection, but definitely personality changes and lack of empathy are going to be quite big. We like Alzheimer's, we have these hyperphosphorylated tau proteins, but they're round. They're called PIC bodies because this is also known as PIC disease. They're round here rather than being tangles. So we have these little tangles here in the Alzheimer's, and here they're just going to be round. You also have a hyperphosphorylation, hyperubiquitination of TDP-43, which is a transcription factor suppressor is one of its roles, but another one of its roles is that it helps with double-strand break repair. So this protein is not able to work the way that we need it to. Creutzfeldt-Jakob disease. So this is going to be a super rapid progression. So within maybe a year of diagnosis, someone's going to die. And that's because we're going to have this amplification of proteins, which we'll talk about. Startle myoclonus. So if you spook them, if you come up and tap them on the shoulder when they're not expecting it, they might just go right into myoclonus, this rhythmic contraction, relaxation, contraction of muscles. EEG will have really sharp waves. You might find 14-3-3 proteins in the CSF. If you do a histological, do a biopsy, look at the histology, you're going to see all of these little vacuoles. They look like, looks like a little sponge under the microscope. So they call it a spongiform cortex. And the way this works is we have a normal protein. It can ultimately eventually be converted into the prion zombie version of the protein, the SC. So prions are very stable proteins. They cannot be damaged by proteases. Normal sterilization techniques like UV or boiling or whatever probably aren't going to destroy them. They're very stable, and they have the added benefit of converting the normal copy of the protein into the zombie copy of the protein. So here's a normal protein, here's the prion protein, and now we have two prion proteins. And it's kind of like a party, right? I invite two friends, they invite two friends, they invite two friends, they invite two friends. Eventually you have this amplification where 1,000 kids show up at your house. Same thing here. One prion protein makes 2, makes 4, makes 8, makes 16, etc. That's why it's going to get you so quickly. All right, so this is a very famous disease. It's very rare, though. And especially what this is most known for is like mad cow disease. This is probably, if you ask somebody about, like, if anybody has heard about it, this is probably where they've heard about it. And I'm just going to go ahead and say, so already this is, of all of this is quite rare. But even here, it's even more rare. Look at this tiny, you can't even see this little sliver, this 0.1%. This is variant Creutzfeldt-Jakob disease, the mad cow disease. So we got this from cows. So in the UK, a lot of cows were infected with this, and I guess they were feeding cows to other cows to save money. And there was a big spike, and 4,000 people, I guess, or so got this at the peak and died. So the cows had bovine spongiform encephalopathy, known as mad cow disease, and people would have a nice steak. And again, you cook the steak, you're normally going to kill the bacteria, but the heat does not denature these prion proteins. They're quite stable, so they get into your body, into your brain, and they can cause the problem for you. We saw a similar thing with kuru, with this ritualistic cannibalism for certain New Guinea tribes. And again, these are famous cases, but they're 0.1% of all of the cases that we'll see. So maybe they were more common back in the 90s, at least the mad cow disease, but nobody's really getting mad cow disease so much anymore. Iatrogenic, so they used to do like surgery on people, and brain surgery, and whatever, somebody's fine, and then of course you sterilize the tools, and then later, a couple weeks later, you got to do another surgery. You use the same tools, they've been sterilized. But remember, the sterilization, the UV, the boiling does not necessarily kill the prions. So we're actually giving prions from patient number 1 to patient number 2. So that's iatrogenic. Some people have just a genetic predisposition, so that whatever, in the 30s, 40s, 50s, 60s, they're more susceptible to have the protein just naturally accidentally fold into a prion, and then of course it's going to have this zombie amplification of the other proteins. And then the sporadic is actually the most common. It's just, we don't really know why, just some people as you get old, I guess it's just a numbers game, right? You play the lottery enough times, you might win. You got enough proteins in your brain over the course of an 80-year life, just by odds, one of them might flip into a zombie protein, and boom, there you go. That's the end of that. SC is known as scrapie. So we see this, it's in humans, it's in cows. It's also in sheep and other animals as well. Related disease, it affects the brain, prion proteins. But they call it scrapie because it makes them itch, like very itchy. And so they would see these sheep just like kind of crazy, and they're just itching themselves so much that they're losing a lot of their wool. So they're scraping themselves against the walls, and hence the name, the scrapie protein.